Welcome to the Intersection Podcast. The Intersection is a project of the Robert Wood Johnson Foundation that creates space for healthcare advocates and leaders to come together and share how they're working to build anti-racist healthcare systems. I'm your host, Anton Gunn. And on a recent episode of the pod, we dove into the topic of reproductive justice. Go back and listen to that episode if you have not already. It was a fantastic conversation, and one topic that came up again and again and again was midwifery and the role of midwives. So we decided to go deeper. That's why I'm happy to be joined for this episode by Star August Ali, founder and executive director of Black Midwifery Collective, and Cassaundra Jah, executive director of the National Association of Certified Professional Midwives. I am a senior advisor to the Intersection as a personal context. I have a daughter who's 20 years old now, the light of my life. She's healthy, in college, doing amazing things, but that's not how she came into this world. It was a disaster from our standpoint, but we were just happy to have a healthy baby girl come into the world and just kind of pushed everything aside. And that's the reason why we only have one daughter today. We don't have multiple children because it was so traumatic. We don't want to go back through it. But as I reflected on it from our conversation about reproductive justice and the context of doing this work, really wanting to create a space for activists and organizers, a place where they can talk, learn from each other, grow, with both of them having the goal to build an anti-racist healthcare system that prioritizes equity by removing structural inequities and barriers in the system to get to better outcomes for all. So, long introduction, but I just wanted you to know who I am and why I'm here. So let's get started by hearing a little bit more about our guests. I'm going to start with Star. Tell us a little bit about you and your work.
So my name is Star August Ali. I've been a birth advocate for over 15 years, first as a doula and then as a midwife. I'm the executive director and founder of a nonprofit organization by the name of Black Midwifery Collective based around the South Side of Chicago. I currently stand to be the first and only Black CPM currently in the state of Illinois offering community-based birthing options, meaning if you're trying to have a birth outside of the hospital and you're looking for a Black provider, I'm the only one currently in the state offering those services. And I got into the work due to my own personal birth experience with a traumatic birth that really could have went completely different, and that really catapulted me into this work. I came to Chicago about almost 8 years ago for the state of Illinois, representing the national chapter NACPM, rose through the ranks of this organization, became their first president of color, and actually passed and legalized the Midwives Practice Act, which they have been trying for over 40 years. Once that happened, I saw that there was a great need for someone really representing people of color in this space in terms of us being able to have autonomy over our body and also being able to make sure that we're able to birth and have options that are safe. I got confirmation when I was at the very end of my training, and I learned that my great-great-grandmother was a grand midwife. So at that point, I knew that it was in my blood.
Awesome. And we're definitely going to unpack some of those things that you shared. Cassaundra, please share a little bit more about you and about your work.
So I'm Cassaundra Jah. I'm the executive director of NACPM. I'm also a CPM. You know, we're going to continue the theme with traumatic birth being how we get into this work and into this conversation. I was not a midwife. That's not what I went to school for. I was an engineer. And when I got pregnant the first time, I had been raised, my family really looked at birth as something normal and natural. I was actually born at home myself. And when I approached my husband about, we're pregnant, it's normal, natural, let's do a home birth, he's like, I hear what you're saying, but let's do the hospital. So I did have a hospital birth for my son, and I had mild to moderate postpartum depression after I had my son. And I look back on that experience and I know that at least in part that was because of my hospital experience being so traumatic. We often call it the gateway profession, the gateway drug into midwifery is becoming a doula first. So that's where I started. My career was out as a doula. And then the word that I think all midwives use, hearing a calling into midwifery. It was after I had my second and I had severe postpartum depression that I began my shift to becoming a midwife. But it was during an appointment, a prenatal, second one with my midwives, that I sat there and I heard the calling. As the executive director of NACPM, we do a lot of advocacy work at both the state and the federal level. There are 37 states and DC that currently license CPMs, but we have a few more left to go. We have 6 states fighting for licensure this year. We have 3 bills at the federal level to help make midwifery more sustainable, to increase access, and to diversify the workforce.
Fantastic. Now, you all are clearly demonstrating why you are the best people to have this conversation with, given your passion and expertise. So I want to unpack and break a few things down. See, the intersection has been recently diving into the topic of reproductive justice, and we've heard a lot about the role of midwifery. So, Star, if you could start, tell us, what is midwifery? How is it different from a doula and different from your traditional clinician that you have in an organization that people can understand?
Okay, so midwives have been here from the beginning of times, known as like the local healer, usually like an older grandmother, an older woman in your community that you went to for anything, any type of element that your family was having. You would come and sit with everybody because our goal at the end of the day is to keep families healthy together. We are medical providers. We're there to provide prenatal, intrapartum, and postpartum care, in addition to woman care. So we're there from the beginning to the very end. We are able to administer medication, catch the babies. We know how to resuscitate if baby comes out and needs a little assistance. We're there if we have a hemorrhage. We know we're trained with all these special trainings. We're trained with our hands. We have this ancient knowledge that does not necessarily immediately result to interventions or drugs or surgery. We use this intuitive knowledge that we've known from the beginning of time to first try to address it from a holistic perspective. And then if we need help, we seek higher level care. We're there emotionally and psychologically as well, because we recognize that the relationships that you have with people around you and your emotional well-being all ties into your pregnancy. We think it's important to serve the communities in which we are in. And that's why it's my goal, my life goal is to make sure that we have a midwife in every community around the world that's able to offer that culture congruency of care, because nobody knows what it is to be a Black woman in America in 2025, but another Black woman that really understands that.
Thank you. And I definitely want to unpack more about tradition of Black midwifery. I want to ask Cassaundra, can you talk about the history of midwifery and the historical racism that tried to eliminate midwifery altogether from the field? So give me some context to that.
This country had an abundance of midwives that were the indigenous healers that were here before the U.S. was colonized, and then the enslaved midwives that were brought here, the immigrant midwives that came by choice. And what happened was a systematic, intentional decimation and erasure of traditional knowledge and of the profession. So how that looked and why that came to be was the rise of medical schools that were for white men and a new profession, obstetrics, right?
Mm.
And the need for patients in that new field. It's supply and demand. It's about money, right? It's about who has the power and how are they going to get their patients and where are they going to get their money from. So it started with pamphlets talking about the dirty, uneducated midwives that were serving their community members. Then began with policies like needing to come under the Department of Health to be licensed and requirements of being able to read. You know, I can tell you one thing I've never done in all the births that I've attended was stop in the middle of a woman pushing so I could read something. And what we saw was by the 1970s, almost the complete erasure of legalized midwifery in this country. When Starr talks about the importance of cultural congruency, white midwives were the minority prior to the decimation. And what we see after that history that I just gave you was this resurgence of midwifery in this country through nursing. It was brought about by primarily white women wanting to create that field. And they created a field made for and by them. And we see the remnants of that today in the low numbers of people of color pursuing midwifery.
Less than 7% of midwives identify as midwives of color in this entire country. That's ridiculous, especially we're here in Chicago and with the abundance of hospital closures and the high need for the diversification of the workforce and the data that's coming out, it's astounding.
Wow. That's a great segue start to what I wanted to ask you about. I live in South Carolina. My mother-in-law is one of 12 children. My father-in-law was one of 13 children, all born in the rural South between mid to late 1940s and the early 1960s. And I think I'm accurate in the following statement that all of those children, 12 on one side and 13 on another, were all born in a rural county with a midwife. So can you talk a little bit about the importance and the tradition of Black midwifery? Everything that we see now is fairly new, but it's not the tradition of where many of our parents and grandparents, how they were brought into this world.
Just thinking about my great-great-grandmother, she was practicing during a time when they had sun up, sun down town. That means that you're Black and you're out when the sun is down, there's a chance of you being lynched, right? She still had to traverse all of that at night to attend births because most births do happen at night, right? Midwives, we were known as the healers, the ones that kept everybody together in our communities. Say we went over to someone's house and we have a sister that's in labor. Like our first thing is we're going to get this house grounded. We're going to get everything set up. Everybody okay? Almost like the mom coming in the house and like, all right, you go and do this, giving everybody assignments, really grounding our entire community. And the time that we're living in right now, that's something that it's really, really needed. When we're putting that into context, if they're able to strategically remove the midwife that brings this holistic healing care, that has this knowledge and wisdom and understanding that's been known to really hold the families and the communities together, that's how they've been able to really come in and to penetrate us, right? This false reality that's now being accepted because we've been programmed to think that the hospitals are the only answers. So when we removed the midwife, it just brought in so much harm and death into our community. As Cassaundra was hitting on earlier, when they started bringing these white OBs into hospitals to practice, you had to have money. It was a white woman's privilege to be able to receive these services. And not that they were receiving the best services, because we had things like twilight sleep, where they were essentially drugging these women and having them give birth under heavy medication, under narcotics. Right now, what's been programmed into us is that birth is an emergency. No, it's not. It's just as natural as having our cycle. And in reality, only 10% of births are deemed as high risk. So if only 10% of the population is deemed as high risk, why do we have the majority of mothers going to a hospital that's literally murdering us? Because we're in a time in history right now where racism is real. It has not left. And it's coming to the care in which we're giving. And so why do we have people that have these positions being able to direct policy, directing resources to a solution that has never worked and isn't working? Even today, it's getting worse. Why not shift the resources into a community-based setting where you have people that are on the ground doing the work? We know how to serve our people. We know what we need. The solution has always been in her.
It's so clear that there's been this shift that we have now to a place of holistic care and really thinking about how we do this in the most compassionate, patient-centered way. So what I'd like for you to discuss now is that given where we are, the fact that we have midwives, that we have doulas, we have lactation services, we have obstetric providers, they're all as a part of the process now in some way, shape, or form. So can y'all discuss the role partnerships between these different types of providers and service providers that can play to create an anti-racist, compassionate, patient-centered birthing process and reproductive care system? What could a good partnership look like to get us where we want to be? And Cassaundra, I'll start with you.
Well, the two things that have been really weighing on my mind recently with things that I'm seeing in legislation is March of Dimes in 2024 published that we're at about 35% maternity deserts. And I'm getting articles sent to me on a weekly basis about hospitals that are closing, L&D units that are closing. The World Health Organization recommends 6 midwives for every 1,000 pregnant people, right? And we're nowhere near those numbers that would be needed for a fully integrated system. So, I think a lot about how do we get there, what would need to change institutionally. I've recently been really thinking about what would it look like if hospitals that began to see they were on the brink, that they're on the road to closure, right? What if instead of whatever they're doing, they poured into the community and into a cultural shift that said, We're going to focus on what we do best, which is high risk pregnancies, NICU care. And when we have low risk patients coming in, we're actually going to encourage them to go to their local birth center, to go to their local licensed midwife. We're going to create relationships with those midwives and, simple handouts to refer these clients out, right? If we focused the attention that they are taking on shoring up hospitals and trying not to close it, rather shifting it towards creating this integrated collaborative system where we have smooth transitions when we do need to change from a community setting to a hospital birth, what would that look like? I think what has happened actually is this really interesting intersection of this history of why birth got moved from home and midwifery into the hospital, but also how we have set up the pay structure in the United States to be not about preventative care, but to be about managing emergencies, right? We could pair these two things up in a way that I think would actually prevent hospital closures and would at the same time increase integration. So that's one thing that I've been, recently really thinking a lot on. And the other is back to this 6 per 1,000 midwife rule of thumb, thinking about how do we get there? And that's around education, right? We have to create that workforce. And so hopefully Star will talk a little bit about what she's doing in Illinois around that. But I'm going to actually point towards one of our federal bills is the Midwives for Moms Act, and it directs educational funds to training midwives at accredited institutions across the country. It's focused on all 3 credentials. That is another piece to this that is difficult for the public to understand. I like to try to really just break it down into there are 2 types of midwives. This is not about a hierarchy. This isn't about who is better. It's not. You have credentialed and you have uncredentialed midwives. And within the credentialed midwifery community, there are 3 types of credentials. The Midwives for Moms Act provides educational funds for those 3 types of midwives with an emphasis on diversifying that workforce, which is the other key component because we can only get to the culturally congruent care if we diversify the midwives that we are producing out of these schools. So, Star, if you want to talk a little bit about what you're doing, I think it's an incredible program and worth some time.
So this historic project that I'm working on is a system change project. It really has the power to change the internal maternal health landscape in the US and to be an example of what could take place in the entire world. I'm installing what will be the first direct entry midwifery program in the state of Illinois. It'll be here on the south side of Chicago. We'll be able to get Black and brown midwives, which really are our priorities, but it's open to everybody, to get them on the ground within 2.5 years. They'll be able to be credentialed and they'll also be eligible for state licensure. And this is important because if we're looking at the maternal health landscape right now, and I'll just use Illinois, for example, we have an abundance of hospital closures. We have horrific data that's coming out that's saying that we essentially are still being slaughtered due to obstetric racism within an industrialized complex system. And yet there's few options for us to birth outside of that. So by investing in community-based midwives, specifically CPMs, we are opening up the door not only to support home births, but we're also supporting birth centers because midwives also staff birth centers. Think about how many midwives we could have. And yes, I know that we have birth centers that are coming up, but in reality, birth centers are almost $2.5 to almost $4 million for 4 brick walls that we're investing in. And mind you, they're topped in terms of how many patients they essentially could take on in a year. They're capped. There's that funding, and we invested it in the workforce. How many clients could each particular midwife serve on top of being able to offer that culture congruency piece and being accessible because you're in the neighborhood? Everybody will be able to have a midwife within their neighborhood. We need to be thinking about it from a systems change approach and not only from a bandage approach, because right now, doulas have been placed as quote unquote the solution. And not to say that doulas aren't important or necessary, but when you're placing them in a hospital setting, they're essentially being placed there to undergird or to shore up a system, a policy that they still have to respect and enforce that's going to continue to facilitate what we're seeing right now, instead of reimagining something that could be completely different, that could be much more impactful for a longer period of time. It's really just restoring, because I really feel like we need to have almost like a reconciliation ceremony. I think if we on a mass level acknowledge what's happened, what Cassaundra described in terms of the history of midwifery, I think that'll be the first steps to bring forth the healing that's really needed. So I'm really excited.
I mean, that's incredibly exciting work. And sometimes the journey and the struggle yields the greatest progress. And so we're really, really excited about that. How can midwives work with hospital systems to make sure that birthing people have the ability to give birth in the setting of their choice? We know the construct is to push people to the hospital and not at a birthing center or not at home and not at these other places. I would love to hear your perspective on that. Cassaundra, I'll start with you.
You know, the word that came to me as you were asking the question is giving information, providing true informed choice and decision making to their patients. I think that starts with is listening. So when your patient comes to you and says, I'm really concerned about having a C-section, you got to be honest and
Yeah.
say your best chance of not having a C-section is not coming to a surgical unit to give birth. It's not going to a surgeon who is a specialist in that. Obstetricians, they're an expert in what they're an expert in, and I want them there when we need them there. And most of us don't need that. And I'm not saying we're the be all end all of everything. There are certainly patients that need to be with doctors from the beginning. When clients come to me and ask for my services, and I have to say, I'm sorry, this is not an appropriate fit, but I can refer you to a doctor who I love and who gives great care. I just wish there was more of that reciprocated the other direction. But you can't do that if you're not in relationship. So really, fundamentally, before you can even begin to tell your patients that you gotta form relationships. So I really think that's the place to start. I think it's with programs like Smooth Transitions out of Washington that facilitates those discussions when transports do happen, that facilitates relationship and honesty, not just between the doctors and the midwives, the licensed midwives, but also with the nurses that receive those patients during transport, with the EMS, and really beginning to create a unified system that can handle those transfers really well.
Very good. Thank you. What would you add, Star?
As I went to go check on a client yesterday, she was almost in tears yesterday, just saying that, she was seeing a provider and this was our first visit. But before seeing me, she was seeing someone in the hospital setting. And she told them that she was going to be having a home birth with the midwife, and their whole energy, their whole attitude completely shifted on. They're like, I can't talk to you. I can't talk to you anymore. Now, what kind of response is that? Should have been something like, I'm great. That's wonderful that you have so many people that care about your support, numerous options. How can I support you? That's typically what a lot of our clients are seeing. And I can even bear witness to within my practice as well. Some clients do choose to have shadow care, meaning you're seeing a midwife, you plan on having a home birth, but you also have a provider in a hospital. And a lot of times, once these providers in the hospital find out that this client is having a home birth with a midwife outside of the hospital system, their own bias starts to creep in. I've had clients that have come back and told me, like, hey, I told my provider I was planning on having a home birth, and they said that home birth was unsafe and I should be careful and I should reconsider. We essentially should be wanting the same thing, wanting them to have the best birth, wanting them to get what they desire, right? Because that's what I signed up for. There needs to be intercollaboration. I mean, Illinois, we just passed the law. I haven't had anybody really reach out saying, how can we best support this new fleet of midwives that just hit the ground in Illinois? Let's intercollaborate. There's no type of agreement. There's nothing. So yeah, we have a long way to go.
I really appreciate you letting people see the challenges and the struggle that it is even till this day. The historical challenges, the policy challenges, the partnership challenges, all of those challenges, which is a great segue to my last question to close us out, is given all of that, all of those challenges, what keeps you going? What keeps you doing this work? I'm gonna start with you, Cassaundra.
It's the clients who want the care that we provide. It's the stories both of the trauma that they or their mother have experienced and the desire for something different.
Mm,
It's the midwives on the ground who are traveling 2 and 3 hours to serve clients in communities. It's the student midwives that call and say, I want to do this. It's the stories of getting pay parity in Virginia that just happened. It's happening in Massachusetts. It's happening in New Mexico. So there are wins, and it does matter, because what we're really talking about is we're talking about people. We're talking about babies, about humanity, and what I would call a human right. Midwifery is not about, do you choose this or do you choose that? It is a fundamental human right. And that is only true if there are midwives. So we have to continue training. We have to continue fighting for those midwives to not just be able to practice because they have the knowledge, but to be able to practice without fear of being arrested, right? We're going to give the care. We can't not give the care when we're not only being called by a divine power, but also by our communities to give that care. That's what keeps me going.
Awesome.
It really is divine human rights to have autonomy over your own body. And we have to stand up against that now. We literally are the guards of the next generation. And what else in this world could be more important than human life? Nothing. This is something we all need to stand guard to right now. Because whatever we don't address right now, we literally sentence our children to inherit that which we don't have the courage to take up right now in our lifetime. And so I remove all fear because I know that I have the Most High with me, and I'm going to continue to move forward and stand guard to the wombs that bore us all. And I usher all of us, and I ask all of us to do the same because there's a lot at stake right now. There's so much at stake, Life is at stake.
Life is at stake. And that's a great point to end, a great last word. Cassaundra, Star, I want to thank you for your work. I want to thank you for your passion. Your perspectives and dedication to advancing reproductive justice are truly invaluable. To our listeners, thank you for tuning in to this episode of the Intersection Podcast. Don't forget to check out meetattheintersection.org, sign up for our mailing list, find out about upcoming episodes and upcoming events. Thank you. The views expressed here do not necessarily reflect the views of the Robert Wood Johnson Foundation. The foundation does not support lobbying efforts, including any activities or communications referenced during this podcast.